Hello everyone and welcome. It's my great pleasure to introduce today's speaker, Dr. Despina Kontos. Dr. Kontos is an associate professor of radiology at the University of Pennsylvania, and her educational background is in computer science, and her research is focused on the role of sort of quantitative imaging and radiomics for guiding personalized clinical decision-making. And she is leading multiple NIH-funded studies that aim to use machine learning to integrate imaging and genomic markers for cancer care. So thank you, Dr. Kontos, for joining us. And apologies for not having this in person. It's great to have us join us online. So thank you.
Thank you so much for the kind introduction. And it's really a pleasure to be virtually with you today. It would have been an even more bigger pleasure if I was able to be there in person, and I still hope that we can make that happen as well in the future. So I guess I'm not sure how you want to do the format of the talk. If we just want to like informally interrupt for questions, or should I just wait for questions at the end? You know, if you have any preference, but.
In normal circumstances, people often ask questions throughout the talk, so I don't know. I'm fine with that.
I'm fine, okay, too. I don't know if I'll be able to monitor as I'm speaking at the same time the chat.
I can take care of the monitoring.
Okay, sure. Component. That sounds great. And if there's any questions, like, feel free to interrupt me. I'll make sure I'll try to stick to about 50 minutes, so we have a little time at the end as well. And so, as I said, very excited to be with you today, and I hope we can resume the in-person visit at some point in the future. So my talk today, oops, sorry, for some reason this is advancing. Okay, so my talk today will focus mostly on the use of radiomics in cancer imaging, and I will specifically focus the talk on the use of radiomics to characterize tumor heterogeneity, and why that is important in oncologic imaging, specific in the context of prognostic and predictive biomarkers. I will focus the overview on some of our studies related to breast cancer imaging, but the paradigm could conceptually be expanded also to other cancers as well. I have no relevant disclosures. And so, taking a step back, what is prognostic assessment, and why are we interested in prognostic biomarkers, specifically for breast cancer? So as new treatment options for breast cancer and other cancers become available, it's critical to have methods that can allow us to select patients that are most likely to benefit from specific therapies. Specifically, as we're getting into an era of various targeted therapies, we often talk about frontline therapy, and then if the frontline kind of therapy isn't working, then we have targeted therapy options or combination therapy options and so forth. In the context of breast cancer, for example, something that has been debated a lot in the past 5 to 10 years is the use of adjuvant chemotherapy in the context of early stage breast cancer. And so some of the conventional markers that oncologists have used in this setting, for example, is tumor pathology information, nodal status, tumor size, grade, receptor statuses, and so forth. And there are in fact different models built on these, based on these factors. So I'm showing an example here of adjuvant online, which, as the name says, is an online model where the oncologist can put all this information and then get some sense of what is the benefit with different therapies option versus no additional therapy, and based on that, make a recommendation. And in addition to some of these more conventional factors, increasingly in breast cancer and other cancers as well, molecular characterization of tumors is becoming increasingly utilized clinically. For example, for breast cancer, OncoDx, it's a very well-established assay, originally developed in the context of node-negative early-stage breast cancer, now also available for node-positive breast cancer and DCIS. And it's basically an assay that is based on 21 genes, the expression of 21 genes that the company Genomic Health has developed an assay based on retrospective and prospective validation that combines an expression of these 21 genes and provides a score based on which the oncologist again can make a decision on whether or not a patient may require chemotherapy based on the molecular characterization of the tumor. And so one would say, okay, we have all these great tools. Why do we also need imaging? You know, we have genomics, we have all pathology, which should be good. But turns out that information alone, it's still not sufficient to help us to best select patients for therapies and predict their outcomes. And one of the reasons that this may be the case, why are those tools insufficient so far, is that at least within the past 5 to 10 years, we're increasingly recognizing that cancer is a heterogeneous disease. And cancer is not only heterogeneous between different patients, that we knew for a while now, but it's also increasingly recognized that cancer is heterogeneous even within the same tumor, a phenomenon that is referred to as intratumor heterogeneity. And it has been studied a lot, the evolution of tumors, starting from stem-like cells to the formation of the entire tumor and branching evolution paradigms and so forth. But the basic premise is, as a tumor starts to develop from like single cells or from a small number of stem-like cells, then it starts to differentiate. And different subclones may develop within the same tumor that may have different characteristics and different driver mutations and may drive the development of the tumor differently. And so when we're characterizing tumors based on information extracted from tissue sampling, for example, with biopsies, we may very well be sampling only one part of the tumor, but missing information from another part of the tumor. And if the tumor is sufficiently heterogeneous, we may be making decisions for therapies and the molecular characterization only for one part of the tumor, while on another part of the tumor, there may be different genetic drivers and genomic drivers that may not respond equally well to that therapy. And if you're interested to learn more about the different models of intratumor heterogeneity, I would very much recommend taking a look at this paper that really elaborates this paradigm of tumor evolution and how the different clones within a tumor can evolve. But not only that, as well as why different tumors may respond different to therapies because of this phenomenon of tumor heterogeneity. So you can see, for example, patient 1 versus patient 2. Patient 1 has a high allelic ratio of the targeted mutation. Patient 2 has a low allelic ratio of the targeted mutation. And let's say you were biopsying those green types of cells, but not those white ones, and you were making your decision based on targeted therapy based on that frequency of allelic ratio, allelic ratio, patient 1 will have a good response, and you will see some of those cells disappearing because of therapy. But patient 2, not as much, because there were a lot of cells that did not have the same targets, and those will continue to grow and ultimately outgrow the cells that were actually responding to therapy. So a tumor may develop resistance, not only not respond to therapy because of its makeup at baseline, but also during the course of therapy, depending on which cells the therapy is targeting, some of the other cells may take over and outgrow the original cells, and then this is the phenomenon that we call as de novo resistance. And so how can imaging help us in this context? And we'll talk a little bit about both how imaging can be utilized to tell us more about this heterogeneity at baseline, typically referred to as prognostic biomarkers, and how can imaging also be utilized to tell us how this heterogeneity evolves during the course of therapy, which may be indicative as to which tumors may be developing this de novo resistance due to heterogeneous molecular makeup. And so, which is more commonly referred to as a predictive biomarkers, because typically those biomarkers are studied in the context of a specific therapy. So let's take a step back and define a little bit the term radiomics. I know it's a buzzword, so let's make sure we're all on the same page about what radiomics refers to. So radiomics refers to the extraction and analysis of large amounts of advanced quantitative features with a high throughput from medical imaging. This was one of the first definitions out there, coined in 2012. And basically, if you want to think about it more broadly, it helps us start utilizing imaging in a way that other assays and other tests have been used so far. Utilizing imaging to extract information in a high throughput fashion, essentially helping us use imaging as a phenotypic assay and extracting expression data in some sense about the imaging phenotype of the tumor. So we'll talk a little about how we can utilize that information. So a radiomic phenotype pipeline typically consists of several steps. For example, identifying the tumor location on imaging data. Here I'm showing an example of a DCA MRI scan with a large breast tumor, developing fully automated approaches to delineate the tumor and then extract various type of features. For example, if we have a contrast agent, such as in DCA MRI, we can extract kinetic information and measurements such as the washout slope, the washing slope, peak enhancement, time to peak, and so forth. We can do that on a voxel by voxel basis and then start getting a better sense of the heterogeneity of the tumor, as I will describe in later slides. And there's also an increasing interest to try to correlate that information from imaging with the underlying histopathology and gene expression data. And so, as I mentioned, an essential step is the fully automated segmentation of the tumor. Fully automated segmentation is useful because, A, it helps us alleviate the inter-rater variability when we have kind of manual segmentation. Although I would say that there's a lot of discussion sometimes in research studies, why did you use one rater and not more than one rater, and inter-rater variability. We recently did a study that looked at the effect of inter-rater variability, not just on the segmentation agreement, which may vary in terms of like the dice indices, but also on the correlation of the extracted feature and their predicted value. And what we found was, which was very interesting, that even if the segmentations don't fully agree and there's a natural variability and not fully agreement by a dice score, the features that you extracted are ultimately quite correlated, and the prediction of the outcomes is also not significantly different. So that's probably the topic of another conversation, but I just wanted to put it out there because it's often a discussion about why don't you have more than one raters, and sometimes it is difficult to do that when you have large data sets and three-dimensional data sets, especially in the current setting with all the restrictions, with the COVID restrictions. It's very hard to actually interface personally with clinicians and be able to do that, and that may be the case for a little while. So fully automated methods can be useful in that concept, especially methods that you can seed and then kind of automatically contour the tumor. And they're important also for extracting particularly morphologic features, so getting information about speculation, diameters, tumor volumes, and so forth. And then, as I mentioned, once we have the tumor segmented reliably, we can extract these features not just in an aggregate fashion that has been the case clinically most of the time or at a hotspot area, but from each voxel within the tumor, and start getting some information about these sub-areas within the tumor that may have different functional profile. So for example, here, if we're looking at the time to peak, and we do it by develop a kinetic curve on each and every voxel of the tumor, not just as an aggregate measure, we can see that some voxels tend to peak at a time point 1, some voxels tend to peak at time point 2, and some voxels tend to peak at time point 3. And these may very well represent different subclones of the tumor with different molecular characteristics, or different, for example, angiogenic characteristics, as we can imagine here at DCMRI. The pixels that have a peak at time point 1 are the ones that tend to uptake that contrast agent more quickly. So they may be related to higher angiogenesis or higher proliferation. And then the pixels, on the other hand, that tend to have the time to peak at time point 3 are the ones who uptake the contrast agent more slowly. So those may be related with a lower angiogenesis and lower proliferation potentially. But you can see how this type of measurements can start giving us a sense of the different areas of the tumor that may be behaving in a homogeneous fashion, and ultimately giving us some information about the heterogeneity. And there's a lot of interest, as I mentioned, about characterizing that spatial heterogeneity, getting information about different areas of the tumor that behave differently. This is also commonly referred to as habitat imaging. And what we see here is an example of a DCMRI tumor as visualized when we're using, for example, a multi-resolution wavelet decomposition on the kinetic features. And again, you start to see some areas of the tumor that tend to cluster together, and that may be useful in giving us information about the subclones that we were talking about. Dynamic imaging modalities, such as dynamic contrast enhanced MRI, although more conventionally it will have a few time points, maybe up to 3, but maybe dynamic PET imaging modalities or other modalities can also start giving us some information, temporal information on the uptake of the tumor, and maybe help us differentiate not just in terms of spatial heterogeneity, the different sub-areas of the tumor, but also help us start to differentiate the temporal component, the functional component of those areas a little bit better. And we've done a little bit of work here in the PET imaging, dynamic FDG PET imaging, where we started looking at clustering not just the voxels in terms of their spatial characteristics, but clustering the voxels in terms of their temporal characteristics, treating them as time series over several acquisition time points, and looking at different ways to try to identify, again, these subregions of heterogeneity and parameterizing that in the context of predicting outcomes. So there are two components to consider, spatial heterogeneity and temporal heterogeneity. I wouldn't call it longitudinal, because that sort of relates more in the course of a therapy, but temporal in terms of the same scan, but different uptake of the contrast agent. What type of features can we extract from images? Well, you probably know this, as much as I do. There are all kinds of different packages out there to do that, and there can be all kinds of different categories of features that can be extracted, hundreds, thousands of them, depending how you extract them and with what parameters. But broadly, one would say there are features that we can use to extract morphological characteristics such as size, circularity, regularity, sharpness of the margins, and so forth. From imaging modalities that also have a contrast agent, we can extract kinetic features, including, as I mentioned, peak enhancement, time to peak, washing slope, washout rate, and so forth. Textural characteristics are also very popular. And sometimes I would say they have become kind of homologous with the same radiomics, although radiomic features are not just texture features. Parallel type features, including contours, correlation, energy, homogeneity, and rung length features, and so forth. And we can also start thinking about more advanced multi-resolution descriptors. I mentioned a little bit the wavelength decomposition. Fractal dimension is also very popular, the Fourier transform, and so forth, which help us identify intrinsic patterns of imaging data that tend to replicate at different scales, such as you know, the fractal dimension. So there are hundreds of features that we can extract, and all of them have different parameters. And so depending with what offset and angular variations we extract them and so forth, we can extract literally thousands of features from imaging data. And that's the notion of the high throughput extraction that I was referring to. So how do we treat that data, right? So if we start thinking about them in a similar context as bioinformatics analysis, as I mentioned, we can start thinking of imaging not just as a diagnostic test, which is the conventional use of imaging so far, but also we can start thinking of imaging as a phenotypic assay, especially in the context of oncologic imaging, that can help us characterize the phenotype, the end result of the tumor. And I would argue that it's probably the only modality that allows us to characterize the heterogeneity of the tumor in vivo. There is, the liquid biopsy option also for some cancers, especially for lung cancer, that has been very much utilized, but it's very difficult to correlate the spatial component on the information we get from a liquid biopsy, and also the sensitivity is very limited. So you may get some information about the variation in different genomic mutations and genomic drivers, but you may not be able to get exactly spatially where they're located in the tumor. And that's, I think, where imaging has a unique advantage. So if you look at this graph on the left-hand side, you see a heat map that most of us are typically used to seeing in bioinformatics type of analysis, right? Where each row represents a sample of the tumor, a tissue sample, and every row represents a gene, and then we're trying to see what is expressed and what is not expressed and identify subtypes and so forth. And I mentioned that we can start thinking of imaging in a similar fashion, that if we're extracting features in a high throughput fashion, then we can start thinking about imaging as a high throughput assay, a phenotypic assay. And so in this graph, every column represents a tumor. Our sample was not done with a biopsy, was done with an imaging modality. And there's been some debate sometimes, but mostly from the oncology community, that will tend to say, like, it's imaging, it's not like real tissue, the biopsy is real tissue, and that is all good. But, imaging is also acquired with a different type of assay. So when you do a biopsy, you get a tissue sample, you put it on a stain, and then you look at it under a microscope to see, what is expressed and what is not. In this setting, we have a tissue, the organ, and then the assay that interacts with it is the imaging acquisition modality. So X-rays, let's say, penetrate, or the protons get magnetized by the magnet. And then the detector of the imaging modality measures that, the result of that reaction. So we do have a reaction with the tissue, it's just a different type of reaction. And what we're getting in the image is a quantitative output of that reaction from all the imaging modalities. So then all these features, each row represents a feature. You can think about it as an expression test, right? So what is the area, the perimeter of the tissue, the tumor, the kinetic features, the standard deviation within the tumor, the mean, the variance, the maximum peak enhancement, the SCR, and so forth, all kinds of features. And then we can apply similar algorithms like unsupervised clustering. There's a lot of literature out there how to do that, incorporating a method. One of the popular methods is SIG-clust and consensus clustering, which basically can tell us where to kind of cut off this heat map and what clusters are there that are statistically significant. We did this study all the way back to 2014 in a small set of early stage breast cancer. And what we were able to see was that two of these clusters, I'm trying to see if the, let me see if this will work. Probably not, the laser pointer. Okay, I got it. Two of these clusters, the purple and the blue, were associated with tumors that were only at low and medium risk of recurrence based on the genomic profiling assay. We know today that tumors at low and medium risk of recurrence based on this molecular profiling assay could safely be spared the side effects of adjuvant chemotherapy. So that's something that the imaging phenotype was able to tell us back then, even just from the imaging data. And then the two other phenotypes, the red, as you can see here, and the green, were associated with tumors at low and medium, but also high risk of recurrence based on the molecular profiling assay, which we know now were the ones that could benefit from adjuvant chemotherapy. Right, so this was a very interesting finding that we could distinguish the tumors based on the molecular characterization. And then I'll show you visually how some of these tumors look like. On the left-hand side, you have a tumor of a 40-year-old woman with recurrence score of 21. That's at the low, medium risk, could be spared adjuvant chemotherapy. On the right-hand side, you have an example of tumor from a 50-year-old woman with a recurrence score of 40, high risk of recurrence based on the molecular profiling assay that could benefit from adjuvant chemotherapy. And here's a different profile of the heterogeneity. On the left-hand side, you can see that most of the pixels, the majority of the pixels are green. So they achieve their time to pick up 2, they have a slower uptake. Here you can see that almost all of the pixels are red. They achieve their time to peak immediately at time point 1. So this could mean that this tumor overall is more proliferative, more angiogenic than this tumor over here. You can see also that it has more smoother margins versus this one has a little bit more spiculated margins. And so if we had biopsied both tumors at the red area, we would have thought that they have exactly the same kind of makeup potentially. But now with imaging, we can see that this is not the case, and these tumors are actually very distinct. And there may be different characteristics for this tumor as part of the green area that we may want to consider in when we're thinking about therapy. So as I'd say, some of the limitations of the currently established prognostic biomarkers is that, the intertumor heterogeneity is difficult to assess. There's both spatial and temporal heterogeneity. The diagnosis so far occurs on the basis of sample tissue. And for breast cancer, at least 30% of women with breast cancer are still estimated to be over or undertreated. So there's potential for improvement. And so that personalized prognostic markers are very important at baseline, at the time of diagnosis, to be able to select even the first-line therapy for cancer. Oops. Any questions so far here? Okay. So I'll show you some results from one of our studies that was published late last year on basically how we evaluated how reliable these imaging phenotypes are and how much independent prognostic value they have. So, okay, we can see that information from imaging, but is it the same, as the one we get from the molecular assay that women are already getting in the clinic? And is it very different from the conventional histopathologic information? And so in other ways, how can imaging really help us here other than, satisfying our academic curiosity of making very pretty graphs and beautiful colored heat maps? So in this study, we wanted basically to see whether or not we can identify such intrinsic imaging phenotypes of tumor heterogeneity for invasive breast cancer, see if they replicate in an independent sample, and see how much they can predict through 10-year recurrence-free survival outcomes. So not necessarily correlate them with another surrogate of survival, but truly correlated with survival, which is one area that I think currently the literature is lacking studies looking at true patient outcomes in similar analysis. So our discovery set was a data set of 95 women who had participated in a multimodality imaging trial at our institution more than 10 years ago. So, one of the problems in this study is kind of the chicken and the egg problem with the imaging. If you want to have follow-up, your imaging modalities may end up being, not current. They may be better, more advanced imaging modalities. So that's something we can keep in mind and always think about how do we make sure that the associations that we detect and the phenotypes that we identify can also replicate in more current imaging modalities. One of the thoughts here is that if we can see a signal modalities that would now be considered a little bit more outdated in terms of like spatial resolution, slice thickness, and so forth, one can only imagine that that signal may even further improve if one were to have more current imaging modalities like higher magnet strength or better resolution and so forth. So this discovery set was comprised of 95 women, all types of breast cancer, newly diagnosed women with newly diagnosed primary breast cancer, for whom we had 10-year recurrence follow-up available. And you can see here some of the characteristics in terms of the subtype, the pathology, the receptor statuses, the stage, and so forth. And so as independent validation, we utilized data publicly available at TCIA and from the I-SPY-1 ACRIN 6657 trial. It is a little bit of a different population, and I'll talk a little bit more about that these cancers tend to be more advanced stage and larger cancers to qualify for neoadjuvant chemotherapy. And then for those women, we had preoperative and pre-treatment DCMR images as well. Also in the discovery set, the images were preoperative, pre-treatment, pre-biopsy imaging data available. So the goals of the study was to identify these, whether or not intrinsic subtypes exist, evaluate the prognostic value and the independent prognostic value as compared to histopathology and conventional prognostic markers, and then look at the independent validation of these phenotypes in the independent validation set, and start to gain a little bit of an insight of the biological interpretation of these phenotypes. So as I mentioned, the first step in this analysis is always segmentation, and we have a fully automated 3D volume segmentation method that was also verified by an expert afterwards. To account a little bit for the differences in scanner acquisition, we first computed the conventional signal enhancement ratio, which basically takes the difference for every post-contrast image to the pre-contrast image, and in that way kind of evens out any systemic differences in the acquisition across different scans. So first we estimated the signal enhancer ratio, and then we extracted a panel of established 3D radiomic features, both gray level histogram, size zone matrix, gray level co-occurrence, run length features, morphologic features, and so forth, using a validated toolkit developed at our institution, the Cancer Imaging Phenomics Toolkit, the CAPTK, that has been extensively validated and also complies with the IPSI feature standardization initiative that a lot of the other toolkits out there also comply with. And it's been shown to be pretty consistent when compared also to other toolkits out there, such as PyRadiomics and other libraries in terms of extracted features. We applied the unsupervised, first we extracted some features. We took out some features with low interquartile range and extreme skewness, features that don't seem to be very informative for our analysis. And then for the remaining features, we constructed that feature signature for each tumor, and we performed this unsupervised clustering to try to identify intrinsic subtypes. The features were color-coded in a way so that more red features means higher heterogeneity, and bluer features tend to mean lower heterogeneity than the negative values. They were sign ranked in that fashion. So after running consistent clustering, we were able to identify 3 statistically significant clusters. You can see here of lower, medium, and higher heterogeneity in terms of the extracted features. For each tumor, we averaged the feature values to create a heterogeneity index for each of the features. And then we also overlaid in the clustering scheme all the available covariates, estrogen receptors, hormone receptors, HER2 status, triple negative, the longest diameter, nuclear grade, the different types of therapies, and obviously the recurrence. And you can see even from a first look that most of the recurrences, except one, tend to cluster in the tumors of medium and high heterogeneity, and fewer recurrences, one recurrence here at the tumors with low heterogeneity, which makes sense because the tumors that have more heterogeneous are the ones who tend to develop more resistance to therapy, as we know from the clinical literature. So the patients with more heterogeneous tumors are more likely to do more poorly. So looking at the heterogeneity index of each of these tumors for the different clusters, we see that it kind of follows the notion that the tumors at the green cluster have lower heterogeneity, the red and have a little bit higher, and the ones at the dark red tend to have even higher heterogeneity. Okay, and here's some example of cells of these tumors. tumor with a lower heterogeneity here, with a medium heterogeneity and a higher heterogeneity here, how the tumor region actually looks like, and the corresponding SCR maps. And you can see that this tumor of a higher heterogeneity has this kind of different like rim around it when you look at the SCR map, and the different, very kind of a little bit more heterogeneous than the other ones in terms of the more outer part versus the more inner part of the tumor. This is a premenopausal woman with primary stage 2 ER negative, HER2 negative, node positive breast cancer. All right, and let's look at a bit of the Kaplan-Meier curves of the different phenotypes. So you can see here the Kaplan-Meier curve for the low, medium, and high heterogeneity. And women, and we built a Cox proportional hazard model. The baseline model, we used some of the conventional prognostic markers that we had available, receptor statuses and so forth. And then we added to that baseline model the phenotype assignment category. So this phenotyping approach is useful because we can go from tens or hundreds of features essentially at the end in the modeling level to one variable, where we can code that variable as categorical or ordinal. Here we code it as an ordinal variable of low, medium, and high heterogeneity based on our assumptions. And so one can start with tens of features as we had here, or hundreds of features, utilize all that information to try and identify patterns in your data set, but at the end, not be hammered by the curse of dimensionality in that sense, especially if you have relatively small data sets with relatively small outcomes. You can just use that one categorical or ordinal variable in the model. And what we saw here is that it resulted in a statistically significant improvement of the statistic in terms of predicting the outcomes. And that's all nice in the discovery set, but ideally the holy grail here is to do validation. So we took the I-SPY data, and the way we went about the validation is not to necessarily recluster the features. We extracted the same exact features with the same inclusion-exclusion criteria, the same exact signatures, but then we took those signatures and we mapped them to the heat map that we identified in the discovery set, right? So we didn't redo the clustering because that would not be the equivalent of like locking your model and then looking for independent validation. We took those signatures, we mapped them based on distance from the centroid of the previous clusters, and assigned each signature to the cluster that was more closer to that in the validation set, and then looked at whether or not these histograms were significant and whether or not the corresponding survival curves had similar outcomes. And so one interesting thing that we found when we did that was that the vast majority of the tumors in this set mapped to the high heterogeneity phenotype, as you can see here. We kind of expected that. It makes sense because this study has more advanced cancer, larger cancers, more advanced stage, and that's why they qualify for neoadjuvant chemotherapy. So it's not surprising that tend to be more heterogeneous. And there may be an association between size and heterogeneity as well to a certain extent. The bigger the cancer, the more likely it is that may have differentiated differently in its growth. But when we look at the outcomes, we can see, again, similar trends here, looking at the Kaplan-Meier curve of the low, medium, and high heterogeneity clusters of the tumors here in terms of their survival outcomes after the therapy. We can see if we compare the heterogeneity indices of the validation set is a little bit different, although there's the same increasing trend. We can see again more cancers tend to be at the medium and high heterogeneity due to the nature of the data set. So that's kind of what we would expect. And then when we looked at the degree of heterogeneity, we also tried to get a little bit of an insight with some of the biomarkers that we had. Mitotic heterogeneity, mitotic states, and MDRG grade for the tumors. We saw that for the well-differentiated tumors, right, those meant to be less heterogeneous, was well-differentiated, had a higher majority of them were part of the lower heterogeneity phenotype. And then as we go into more the poorly differentiated tumors, we saw that the vast majority of them were either a medium or high heterogeneity from the imaging biomarker, which makes sense. If they're more poorly differentiated, we'd expect them to be more heterogeneous. And then when we're looking to get a mitotic stage, we saw that the tumors at low mitotic stage, mostly, kind of half and half and low heterogeneity with medium and high. But then when you go to tumors with high mitotic stage, you can clearly see that the vast majority of them are part of the medium and high heterogeneity imaging phenotype, which again makes sense from a biologic standpoint. And then we're looking at the estrogen receptor percentage across the different heterogeneity phenotypes. We found a statistically significant difference between the low and high heterogeneity phenotypes as well when we compared, which is an interesting observation. So in this study, we looked at the prognostic setting, right? Getting that information at baseline where we make decisions about where we assign therapy upfront, where we identify tumors of imaging phenotypes of tumor heterogeneity. We have replicated them. We looked at the replicating a completely independent validation cohort from different institutions. Actually, the validation set is multi-institutional. It reflects, it's a data set collected from several sites in the United States and Canada. The discovery set was just within the University of Pennsylvania. We showed that these phenotypes seem to have independent prognostic value in predicting 10-year recurrence-free survival. You know, as I mentioned, some of the limitations is an older imaging acquisition protocol, and the validation cohort, although only had advanced stage tumor, but that's kind of interesting because the results validated even in that context. So as a future step, we need to replicate the findings in larger cohorts and also look further between associations with the imaging phenotypes and genomic markers to start to get a little bit more an interpretability about what these imaging phenotypes mean. And we're a little bit limited here because we want to do this thing with imaging because we want to augment information from biopsies, but at the same time, the genomic information that we have and the histopathologic information that we have is acquired with these type of biopsies. So we're sort of correlating an imaging phenotype that relates to the entire volume with a molecular or histopathologic information extracted from just one little part of the tumor. So we have to think about that a little bit more and how we can ultimately do a study that can really establish this mapping between an entire volume of tumor from a radiomic perspective to a histopathologic perspective, and perhaps some of the more recent work with digital pathology can give us the opportunity to really go inside the tumor and try to map macroscopic with microscopic imaging and see whether or not we can use conventional radiologic imaging to really hone down into the heterogeneity of the cancer and interpret that heterogeneity from a biologic standpoint. So this is, I think, an area that could have a lot of promise for the selection of targeted therapies, immunotherapies, and so forth in breast and other types of cancer as well. And as I mentioned, you know, these biomarkers can also be used to look at changes in heterogeneity during the course of therapy. As I mentioned, one of these studies is the Akron 6657 I-SPY1. We use this data for the validation of the phenotypes at baseline, but it can also use this data to look at how the heterogeneity phenotypes evolved during the course of therapy. You can see that this therapy imaging was acquired at baseline, which is what we use for our previous validation, but is also acquired early in the course of therapy, midpoint therapy, and right before therapy. This is a trial of neoadjuvant chemotherapy. So we can start thinking about, can we use these heterogeneity markers to look at how the heterogeneity changes? And that, does it indicate that the tumor is developing de novo resistance to a therapy, or does it indicate that the tumor is sort of remaining homogeneous and responding well to therapy? And so here we don't only have the different time points in terms of the single acquisition, but we also have the different time points during the course of therapy, where particularly we can start thinking about utilizing image registration, not to only extract those measurements at each time point in therapy separately, but utilize registration to bring these different scans into alignment so we can monitor changes of tumor heterogeneity and radiomic features over time at a voxel by voxel level, right? And so getting, again, the information about heterogeneity, and if we're looking further in registration-derived features, so deformation fields, Jacobian deformation, and so forth, anisotropic diffusion indexes, and other measurements of registration, we can also get a voxel by voxel measurement of tumor deformation. So is the tumor shrinking, expanding, at which areas, and so forth, and on top of that, evaluate feature measurement differences, what is commonly referred to as a parametric response map. That's something that the registration can allow us to evaluate and develop as well. So in this concept, we will take the pre-treatment scan and the follow-up, apply the registration and tumor segmentation, and extract the deformation features that I was talking about, but also parametric response maps, for example, of kinetic features at each voxel over time, and try to model their differences. And so I'll summarize these results a little bit, but I'm providing related citations to any of you that may be interested in sort of diving deeper into this analysis, since we just have a little bit more time left. But basically what we've been able to show is that both in looking at predicting pathology complete response, but also in predicting survival outcomes for patients longitudinally, that, and especially early in the course of therapy, because ultimately we want to use these markers to say, this patient is not going to do well under this therapy, so spare them from the unnecessary side effects, and let's put them in this different therapy or this targeted therapy, and so forth. And there are different pros and cons for different therapies, right? So immunotherapies or targeted therapies may be more expensive or more targeted to specific mutations. They may have their side effects as well. And you may not want to put a patient there at baseline if you think that they have a chance to respond to something that's more standard and conventional and maybe fewer side effects. So there are a lot of decisions that have to be made there. So ideally, you want to know early in the course of therapy which patients are not going to do well in the therapy you have assigned to them. So we looked specifically in changes of heterogeneity from baseline to the early time point of therapy as a predictor of a response. And we wanted to look at a few things. First of all, how some of these features that we're extracting can augment the conventional functional tumor volume measurements that have been the gold standard. How the voxel-wise analysis, which in theory should give us more information about heterogeneity, can augment the more aggregate type measurements. So from averaging a measurement over the entire tumor over a hotspot, and if we have more refined information, can we get more information about heterogeneity? And then if we put all this information together, do we do better about predicting outcomes? And so we were able to see with cross-validation experiments in that setting, we didn't have an independent validation set yet, although we're trying to think about utilizing the I-SPY2 data, that these voxel-wise features were able to improve the prediction of PCR versus when we're talking about aggregate features, so features that are extracted as average from the entire tumor volume or from hotspots, which is something that, again, makes a little bit sense. And similarly, when we look at survival, the statistic increases significantly when you're looking at aggregate features versus these voxel-wise registration extracted features, even when you account for conventional clinical features and the conventional functional tumor volume. And here you can see how these curves kind of look like when you go from baseline features that include the functional tumor volume to the aggregate features to the voxel-wise analysis. We get better separation. But also these phenotypes can augment functional tumor volume itself, which is the current gold standard. And here, for example, for the I-SPY data, you can see the survival curves if you dichotomize the patients by functional tumor volume 2, which is the early treatment time of functional tumor volume. And these very much replicate the Kaplan-Meier curves published also by Dr. Hilton in their paper in Radiology in 2016. And then you see here what happens to each of these curves, where you further substratify them by heterogeneity phenotype. And you can see that this curve breaks down. And one curve becomes the one that really, really seems to do worse. And the other curves tend to kind of cluster together up here, even though some of these women were originally in the blue curve that were predicted to do worse just by functional tumor volume. And so these may be the women that are really deemed to not do well from this type of therapy. And for those may be the ones who need to be assigned to a different therapy early in the course of treatment in order to do better. So these are some of the concepts that we're interested in further validating in a prospective study, and we're working together with Dr. Hilton's group to see if we can apply some of these metrics also in the I-SPY2 trial, which is an adaptive clinical trial designed with several arms of targeted therapy. So ultimately, I guess the vision here is, how do we integrate all that information? And we're moving towards an era that we can't be looking at any of this information in isolation. We can't just be looking at imaging and making a model just based on imaging data, but ignoring electronic and medical health record data or histopathology data or molecular profiling data. But also we can't be looking into any of the other data on its own without considering the effect of the others. So from a modeling perspective, I think where the research and clinical relevance is moving towards what we would like to call as integrated precision diagnostics. Developing these models that will integrate information from imaging, electronic medical health record data, digital pathology, conventional histopathology, genomic and genetic data, and put that information together to create multiparametric models that will allow us to personalize screening, prognostic assessment, therapy response evaluation, and so forth. And I think this is kind of a golden era for experts like yourselves in the statistical field to try to work a little bit in the interface of machine learning and multi-omic integration methodologies to try and think about what's the best way to do that. I think the era where we sort of throw everything in one model and hope that it predicts, it's kind of starting to fade. And we need to be thinking, how do we utilize this data that in each of these buckets, you have high dimensional, highly correlated data, but between them, they may not be as much correlated information. And how do we build models that are parsimonious enough that will give us reliable predictions and generalize well, but at the same time, utilize the wealth of the information that is kind of embedded in this data. And I think there's a lot of work we can do in the interface of machine learning, deep learning, multi-omic integration, and conventional biostatistics to try and bring kind of the best out of all these methods, but at the same time add some interpretability, because black boxes are not very good either when you want to use them in the clinic. We have to be able to understand what we make certain decisions and gain insight also from this data that we can then translate to novel therapies and preventative approaches. Not just to satisfy academic curiosity why a decision is being made, but if these methods can tell us that, if this factor is higher and this factor is lower, then you might have a higher risk to respond to this therapy, or we are more susceptible to this disease, then maybe we can go back to the drawing table and do something about these factors. So I think adding interpretability in this modeling approach will be very, very important. And I think only if these different kind of statistical disciplines come together, we have a decent chance at materializing some of these modeling in the future in an efficient manner. As I mentioned, there are several packages out there that can be used to extract radiomic features. So in this day and age, one doesn't necessarily need to be an expert in image analysis to extract radiomic features. Here I'm just showcasing one of the tools that we have developed here at Penn, the Cancer Phenomics Toolkit, which was used for our study, and basically has a graphical user interface and a batch processing mode and automated segmentation libraries incorporated that you can extract radiomic features, at least the conventional radiomic features, from an array of different imaging modalities, and then being largely agnostic to you don't have to code these features yourself, but you can start using them in your analysis. And I think there are several toolkits like that out there. PyRadiomics is another popular library, and so forth. And I think these tools can make it easier for people to do this type of analysis and make it a little bit more broadly utilized, but also allow for people to, in an open source setting, contribute their models in this context as well. And again, all this kind of toolkits allow both more kind of basic level functions, segmentations, registrations, generic kind of methodologies, to even incorporating models for prediction and allowing users to incorporate their data. And I think we may have an opportunity with approaches such as federated learning to utilize some of these tools without having to share data necessarily across institutions. That always makes things easier, but being able to share models and ultimately have these tools learn from different users and help us build these tools in a way that would be more generalizable as well if they integrate data from various sources. And with that, I would like to stop and leave a little bit of time for discussion as well. I'd like to thank you all for your attention and the opportunity to virtually join you today. I hope this was an interesting learning experience for the past hour or so. I want to thank also very much our clinical collaborators, without whom none of these research would be possible. All these work comes out of stimulating discussions and interactions with them. And this is actually something that I'm very concerned in the current setting of remote work and teleworking that we're going to start missing very much. And if this goes on for quite some time, we might start seeing some of these side effects on the quality of our research as well. All of the lab members who do the actual hands-on work and hands-on research. We actually had a chance last week after almost February to get together for a picnic in a very socially distant way and safe way, and be able to interact with each other and have lunch and catch up, which is something that we hadn't done in person for a long time, and that was very refreshing. And our collaborators at Penn, as you can imagine, this type of work is very highly multidisciplinary, involving oncologists, in addition to radiologists, oncology, pathology, genomic medicine, primary care, biostatistics, epidemiology, cancer biology, and so forth. And obviously a lot of collaborations across different institutions, including some of the work that we're doing together with Dr. Gachanis here at Brown. So thank you very much for your attention, and I would be happy to answer any questions that you may have.
Yeah, thank you, Despina. Very, very interesting. Are there any questions? I guess I have a question regarding sort of the role of, when you're building a risk prediction model, the role of treatment. Are you thinking about the risk prediction model within, especially in these sort of health records where treatment is decided based on other factors and so on? How do you, I've always found it a bit confusing how to deal with those kind of settings. Like in traditional studies, I see you build a risk prediction model within a specific arm. But when treatment is sort of based, there's a dynamic treatment going on. Do you have any thoughts on that? I know it's a little
That is an interesting question, and it is a little bit challenging. Yes, like ideally you can try to create a very, very clean kind of cohort and just look into one specific therapy. But in our case, for example, we coded for the different therapies. Broadly, we categorized kind of like, just a radiation therapy, endocrine therapy, and chemotherapy, or their combinations, like as a categorical variable, and included that in the models to see if there's any interactions in the phenotypes that we identified, or any significant differences and so forth, and how they may be affecting the outcome of the model. But it's obviously very tricky to do that because you either need to have a very, very clean data set or account for it in the modeling, because obviously there's no cohort of women, and there shouldn't be any cohort of women that has no treatment to see really the outcome.
Sure, that makes sense. Thanks. Any other questions?
John, are you looking at the hands?
Oh, no, I am. No, I don't even know how to look at the hands.
You go to participants and then you just press it.
I see, okay. Oh, yeah, Konstantin, so you have a question?
No, I had a question, but I thought maybe there are others. I didn't look down the list.
I think you are the only one with your hand up now.
Okay, well, all right. Just to let everybody know, there is a raise your hand feature in all this. Listen, I have two sort of not quite related questions. One is, in the voxel analysis, does spatial correlation play a role there? Do people think about it? Or are they still integrating in a sense?
I think the spatial correlation does play a role. And when we looked at the modeling of the time series, when we looked at the dynamic data, the PET data, we try to incorporate that as well, like some spatial component of the correlation using a Markov model on the spatial domain as well. It does play a role. Yes, features that tend to be closer spatially tend to have similar characteristics when it comes to radiomic features.
I see. Okay. So because that's quite a complex type of set of considerations to put into the models. So the models with the features, they kind of the features integrate over the whole image in a sense, because they are means of this and quantiles of that and so on and so forth. So that's a very different direction. In the features, do you want to say a word about how does feature standardization play into this? We were talking about it earlier.
Right. Yeah, that's a very important point. In this data set, we did something, very simple. We, in the discovery set, all the cases were part of the same clinical trial. So it was in a single institution study, and the purple was very well controlled, and there was not much heterogeneity in the acquisition. And so we just did conventional SCRs, thinking that before extracting features, that the SCR itself can account a little bit for that variability. Then the validation set was the I-SPY set, which also has relatively well-controlled acquisition protocol, even though it's a multi-site study. But we did the similar kind of SCR, trying to take out a little bit of that effect. We probably could have looked more into that. Some of the ways that we're starting to adopt in our analysis now in other studies is try to address the aspect of radiomic feature standardization utilizing approaches such as COMBAT. I don't know how much people are familiar with these approaches. COMBAT was a technique that was originally developed for genomic data analysis and gene expression standardization and so forth, and has recently been adapted also in the radiomic setting and imaging feature measurements. So we're looking at how to refine these methods a little bit to account for variability when you know that you have certain factors that are different between your data sets, for example, slice thickness, resolution, or dose, or reconstruction kernel in CT, and so forth. And how you can look at any systemic biases from those covariates in your feature set, and then what transformations you need to apply to make, let's say, different feature sets more comparable based on similar covariates. So that's something to be thinking about, in addition to using some software that is already sort of validated in terms of complying with some more broader standardization initiatives, like the IPSI initiative that AAPM and other entities have endorsed, and a lot of the other toolkits have also been sort of applied. And there's a paper published in Tomography last year, for example, for the IPSI initiative, where they took like the same phantoms and had a bunch of different toolkits applied and made sure that the features are correlated for all the toolkits for the different phantoms and the different settings and so forth. So I don't think there's one hard and gold standard way of doing it, but I think probably the best bet for doing something like that is to use a tool that adheres to some of these standards in the first place, and then inspect the features. Look, for example, to if you know that there are certain factors that are different, start by looking at those and see if you see different distributions of the features. So apply some distribution tests that look at this changes in differences in different distributions or bimodalities based on your factor and so forth. And if you see that some systemic differences exist, then you start thinking about maybe applying a post-processing approach to try and make your feature sets more comparable to the degree possible. Now, my notion has always been that if we're looking for patterns at the population level that can be so predictive and so distinct, if they were patterns that could be completely alleviated due to some noise in imaging acquisition, then there are probably going to be some patterns that they're not going to be very useful to us, because this variability will always exist. We're never going to be able to completely eradicate it. On the other hand, if there are some patterns that can truly be very predictive and clinically very significant with significant, let's say, odds ratios or hazard ratios, and there's really something to it, I want to hope that there will be some patterns that they may be affected, the signal may be affected by some noise from the acquisition, but not completely alleviated. So I would think that some of these feature cleaning approaches, you're basically cleaning the signal. So if there is a signal already there, it will make it better, But I think but it's not like something that will make or break a study completely. It will improve your signal, but it won't make a signal if it doesn't exist. And if it's weak enough, it will still, I think, not bring it enough up to have clinical significance. Of course, there's one thing to have statistical significance, and if you have large enough sample, you can find significance for very, very small odds ratios or hazard ratios, but is that meaningful clinically? Maybe not, right? So I think the true signals can be improved by some ways of standardizing the features, but I don't think it's ultimately what makes or breaks a study. That's my personal opinion, and I'm happy to debate it.
No major debate from me. Thank you very much for the presentation. I think it gave us a great introduction to this area, an overview that I think a lot of people will find useful.
Thank you very much for having me, and I think the presentation is recorded, and happy to make the slides available. I think I already made the slides available, so if anybody has any questions, feel free to email me, and I think we're still hanging out for a little longer in the afternoon, so I look forward to talking to some of you in more detail.
Yeah, thank you, Despina.
Thank you, John. Thank you very much. So I guess we're having a little lunch break now, and I'll see you all around 1:45.
Yeah, thanks.
Thank you.